Traditional transvenous ICDs have been shown very high efficacy and they save lives. There is a big downside to transvenous ICDs, and that's the fact that they have a transvenous lead. So obviously all types of complications associated with transvenous leads are things we would love to avoid. And now in the last decade we have the subcutaneous ICD, where the lead that connects the S-ICD to the heart and that reads the signal of the heart is not inside the heart and not inside the vasculature, but is actually outside the heart, and it's actually just subcutaneous. So that means that all complications related to a transvenous lead in the vascular system into the heart are actually avoided, and I think that that is a big advantage of these of the S-ICD, to get rid of all these lead-related complications. In prior S-ICD trials and registries, there was a miscellaneous population. So there was a wide variety in patients that were implanted with an S-ICD. And it was different from the classic pattern that you see with transvenous ICD, which is the more classical and conventional pattern, where many patients have a primary prevention indication and have a low ejection fraction. That's the majority of patients that receive ICDs nowadays. And so the UNTOUCHED registry was actually needed to see whether in this population, which is the more conventional classic population, which was present in prior S-ICD registries but was not that big. The UNTOUCHED population is actually primary prevention, all patients with a low ejection fraction, so this population more closely resembles that classical population that is served with a transvenous ICD. When we look at the UNTOUCHED population, there are differences with prior S-ICD studies and registries. So the biggest difference is that in this UNTOUCHED trial, the primary prevention indication and low ejection fraction was the unique feature of inclusion. So that was the main inclusion of these patients. And what we see when we compare these to the other registries, where we also had some patients with low ejection fraction and primary prevention, now we have patients, 100% of patients has that indication of primary prevention and low ejection fraction. And what we also see when we look at this population, we have more patients with hypertension, more patients with heart failure, patients who are a little bit older. So we see that this is a more ischemic patients. So this is a population that's a little bit sicker and has more comorbidity compared to prior S-ICD registries. So what we observed in this population, we had more than 1,100 patients with a primary prevention indication and with a low ejection fraction. What we observed is that, similar to what we saw in the prior registries with the S-ICD, that we had a high complication-free survival of these patients. So there was a low complication rate with the S-ICD, which was also found in the prior patient populations with the S-ICD, but this is again confirmed in the current population with a low ejection fraction and the primary prevention indication. So that is one thing that we observe. The other thing we observe is that we have a high conversion efficacy of the S-ICD, so similar to what we've seen before. We again confirm that with the S-ICD we see a 98% to 99% conversion efficacy of ventricular arrhythmias during acute testing. So that is also, I think, important. We don't know yet how this will run in the long term. Obviously, to compare these data to MADIT RIT, we now have a similar population than what we've seen in MADIT RIT, so low ejection fraction primary prevention patients. But we don't yet have the long-term outcome of these patients with regard to appropriate and inappropriate shocks. So we will have to wait for the long-term outcome data to compare outcomes of the S-ICD in this population compared to the transvenous ICD in MADIT RIT. What we see in this trial, that the settings were actually higher. So the cutoff rates for detection of ventricular tachycardia and ventricular fibrillation were above 200, which is now the recommended setting for patients with an S-ICD. And we've seen that this adoption to this program is very high now in real life, and we hope that this will prevent unnecessary inappropriate shocks. Obviously, we will have to wait for the long-term data to show that, and then we can compare this to the MADIT RIT data to see whether this comes into the same inappropriate shock rates as what we see with the conventional transvenous ICDs.